Welcome to the Explainer. Today, we're hitting the floor and going on clinical rounds to really master the complex and, let's be honest, sometimes intimidating pharmacological data for 4 major neurological conditions. You know, when you're dealing with the nervous system, these medications are incredibly powerful, the therapeutic windows are super narrow, and the stakes for the patient are quite literally as high as they get. So my goal today is to give you a highly visual framework. This way you can confidently understand the tools we use, the traps you absolutely have to avoid, and the exact clinical tactics you need to deploy. Let's get started.
All right, let's take a quick look at our agenda for today's rounds. We'll be moving sequentially through 4 main areas: managing myasthenia gravis, modifying multiple sclerosis, balancing Parkinson's disease, and controlling seizures. Section 1. Managing myasthenia gravis.
So the core physiological problem with myasthenia gravis is profound muscle weakness. To tackle that, our go-to tools are the anti-myasthenics, which you'll also hear called anticholinesterase medications. Drugs like neostigmine bromide and pyridostigmine are going to be your daily drivers here. By blocking the breakdown of acetylcholine at the neuromuscular junction, they basically keep that neurotransmitter firing the muscles. This is absolutely critical because that weakness can actually impair a client's fundamental ability to swallow and even breathe. You'll also notice edrophonium on this list, which serves a very specific diagnostic purpose, and that brings us to a major clinical trap.
Now here is the trap, distinguishing between a myasthenic crisis and a cholinergic crisis. To the untrained eye, both of these present with severe, life-threatening muscle weakness, but they are caused by complete opposites. A myasthenic crisis means the patient is underdosed. A cholinergic crisis means they are overdosed and essentially toxic. So to figure out which one is actually happening, we use the edrophonium test. If you give edrophonium and the muscle tone temporarily improves, that's a positive test, meaning you have a myasthenic crisis. But if the muscle tone gets worse and you start seeing twitching around the eyes and face, that's a negative test, meaning you're dealing with a cholinergic crisis.
You know, this edrophonium test is incredibly high stakes. It's almost like a magic trick. You inject it intravenously and watch for a significant improvement within just 30 to 60 seconds. But that speed comes with immense danger. This test can trigger severe bronchospasm, bradycardia, and even cardiac arrest. Because of that, having emergency resuscitation equipment and atropine sulfate, which is the antidote for this overdose, drawn up and ready, is an absolute life-or-death necessity.
Because the stakes are so high, your absolute most crucial tactic as a nurse is precise timing. You have to administer these medications exactly on schedule to maintain steady therapeutic blood levels. If those levels drop, the patient becomes too weak to swallow safely. Notice the strategic timing here. You give the meds with a small amount of food to stop GI upset, but you wait 45 to 60 minutes before having the client eat a full meal. This perfectly aligns the peak medication effectiveness with chewing and swallowing, which drastically decreases the risk of aspiration. And since this therapy is lifelong, wearing a medical alert bracelet is completely non-negotiable.
Moving right along to Section 2, modifying multiple sclerosis. Unlike our last stop with myasthenia gravis, where we focused on immediate neurotransmitter levels, our focus with MS really shifts toward actively modifying the overarching progression of the disease itself. Our tools here fall into a few distinct categories. First, we have immunomodulators, like interferons. These are designed to decrease the frequency of relapses and actually reduce brain lesions. Then we have immunosuppressants, like mitotoxintrone, to heavily suppress the immune response. But when a patient experiences an acute, severe relapse, we have to shift gears to the bottom of the clinical toolbox. That's when we utilize heavy-hitting IV glucocorticoids to rapidly suppress that acute inflammation.
But as you can probably guess, manipulating the immune system comes with a heavy cost. You've got to monitor your clients closely for these dangerous traps. With immunomodulators, you are specifically watching out for hepatotoxicity, so your liver function tests are key here, along with myelosuppression and severe flu-like reactions. With immunosuppressants, the risks escalate even further. You must be hypervigilant for severe cardiotoxicity, fetal harm, and injury to the gastrointestinal mucosa. These aren't just minor side effects, guys. They are profound systemic risks that require your constant clinical attention.
All right, Section 3, balancing Parkinson's disease.
If MS was all about modifying the immune system, Parkinson's is really about restoring a super delicate physiological balance right in the central nervous system. The main issue here is a deficit of dopamine compared to acetylcholine. Think of the brain as a seesaw. Dopaminergics are our primary tools to push those dopamine levels back up. By stimulating dopamine receptors and increasing the available dopamine, we essentially restore that balance to maximize the client's functional ability.
On the flip side of that seesaw, we have anticholinergics. If we can't get the dopamine levels up enough, we push the acetylcholine activity down by blocking cholinergic receptors in the CNS. This is highly effective for reducing tremors and drooling, though it really has minimal effect on bradykinesia and rigidity. But there is a massive clinical red flag here. These medications are strictly contraindicated in clients with glaucoma. Why? Because anticholinergics can dangerously increase intraocular pressure, and we absolutely want to avoid that.
So how do we manage this day-to-day? You've got to clearly instruct your clients on some really specific tactics. First off, the dietary rules for dopaminergics like carbidopa-levodopa are pretty unique. High-protein diets actually interfere with the medication's availability to the brain, so clients must divide their daily protein evenly among all their meals, and they need to avoid excessive vitamin B6. You also have to teach them to change positions slowly to avoid orthostatic hypotension, and warn them that abruptly stopping their anticholinergics will severely intensify their tremors. Finally, save them a massive panic attack by letting them know that a dark discoloration of their urine or perspiration is a completely harmless side effect. It's totally normal.
As we wrap up Parkinson's and managing its intricate balances, it naturally leads us to ask a critical question about our fourth and final condition. How exactly do we stop abnormal neuronal discharges before they cascade completely out of control?
And that brings us to Section 4, Controlling Seizures.
Our entire goal here is literally just preventing the spread of those chaotic electrical discharges to neighboring neurons. Hydantines, specifically medications like phenytoin, are our absolute primary tools for this. They are the heavy lifters, treating both partial and generalized tonic-clonic seizures. And fascinatingly enough, they can also treat cardiac dysrhythmias. But you have to monitor for the classic trap of gingival hyperplasia. This causes reddened gums that bleed very easily. You also want to keep an eye out for unexpected spikes in blood glucose and any signs of CNS depression like slurred speech or confusion.
Your role as a provider working with these medications requires meticulous attention to detail. You must initiate strict seizure precautions and constantly monitor serum blood levels to make sure you are staying right in that narrow therapeutic window. But there is a huge trap here regarding feeding tubes where so many people slip up. If your patient is on enteral tube feedings, the formula itself actually interferes with the absorption of enteral phenytoin. You have to actively schedule and separate the tube feedings from the medication administration, or the patient simply won't absorb the life-saving drug. It's that simple, but so easy to miss.
Oh, and speaking of administration traps, there's an absolute must-know rule for IV patient safety. When you are administering phenytoin intravenously, you dilute it only in normal saline, literally nothing else. If you mix it with dextrose, the medication will precipitate out of the solution into solid particles right inside the IV line. As you can imagine, that is incredibly dangerous for the client.
When you look at the clinical pyramid of patient safety, it really reminds us that mastering these neurological medications is way more than just memorizing a list of drug names. It's about building a rock-solid foundation of targeted physiological knowledge. It's deeply understanding the specific tools available to you, recognizing and avoiding those deadly traps of side effects and interactions, and then executing precise, timely clinical tactics.
So, as we wrap up this explainer and you get ready to head back out onto the floor, I want to leave you with one final, crucial scenario to think about, just to solidify your learning today. If you have a Parkinson's patient presenting with severe new-onset tremors, but they also have a history of glaucoma, how exactly will you restore their neurological balance without risking their vision? Think on that. Thanks so much for joining me on Rounds today, and I'll see you on the next one.